Could we start?
Yeah, please.
A very good evening to everyone. We welcome you all to our next session of IS National PG online classes. And the topic for today's discussion is anesthesia and intensive care management of patients with sepsis and septic shock. As is it customary, we always start with Saraswati Vandana.
Just wait.
Okay, sir.
Yeah, please.
Saraswati Vidyarambham Karishyami
Now I would like to invite our Honorary Secretary, IS National, Dr. Sukhvinder Bajwa, to start the session.
Thank you, Dr. Jyosna. It's my pleasure to welcome Dr. Rajesh Mane and Dr. Manjunath Patil for this very prestigious class. The topic is very apt, almost changing every 6 months. The newer sepsis guidelines coming, the newer sepsis studies coming. So sepsis and septic shock. The students also getting a long question, and as well as they're seeing these type of patient in the critical care units. So there are many doubts. I think we'll try to finish maximum of the topic in this class. If it's not finished, we can have another class also. So that also depends upon our brilliant student, Dr. Neha and Dr. Aneshwari. They will be trying to answer almost everything. So be courageous, don't worry, don't make a blunder, because this is a very important topic globally, not just in India, globally. So I welcome you all and welcome all the audience, the senior people. I can see them also. Everybody is welcome here. So let's start the class. Jyosna, over to you, please.
Thank you, sir. Now I would like to invite our co-coordinator for today's session, Dr. Mithila Reshmi, Junior Consultant, Apollo Hospitals, Visakhapatnam, to introduce the speakers, to introduce the faculty.
Good evening, everyone. It's an honor to have Dr. Rajesh Mane, sir, who's the professor and HOD of anesthesiology, as the moderator for today's class. He is currently affiliated to Jawaharlal Nehru Medical College, KLE Academy of Higher Education and Research, Belagavi, and he has done fellowship in respiratory care, USA, and he is a member of Brain Death Organ Transplant Committee and a member board of study Kahir, Belagavi. And he is also a coordinator for KLE Simulation Center and Clinical Skill Lab JNMC Belagavi. His main area of interest being regional anesthesia and difficult airway. He has numerous publications in Indian Journal of Anesthesia, Saudi and Sri Lankan Journal of Anesthesia. He has been a faculty speaker at state, national and international conferences. And I would also like to extend my warm welcome and to Dr. Manjunath C. Patil, sir, who is a professor in the Department of Anesthesiology from JNMC, Belagavi, his alma mater being the same, Jawaharlal Nehru Medical College, Belagavi. His academic experiences is that he has attended several regional, national, and international conferences and conducted many workshops and CMEs. He has delivered guest lectures and also presented paper at NISORA and ESRA International Symposium. He has guided over most of the postgraduate students for many award-winning scientific papers. He's also a committee member of the Board of Studies at Kahir and Karad, Maharashtra, and he is a member of KLE Advanced Simulation Center and Clinical Skill Lab, JNMC Kahir. Welcome to both of you, sir. Now I would request you to introduce the students, Dr. Neha. for today's session.
Yeah. Good evening, everyone. On behalf of the Department of Anesthesia, staff and students, I extend a warm welcome to all the participants for this wonderful teaching session, which the ISN National has started. A good platform where so many interesting topics, important topics are being shared. Today's topic is on sepsis, the anesthetic and the intensive care management, which, as Sukhinder Bajwa said, very globally challenging to all of us. As you know, anesthesiologists are quite uniquely adapted or skilled in resuscitation, monitoring, as well as they have the unique ability or suited for this role, wherein where timely and adequate appropriate management is required to overcome this huge global burden. Today we have amongst the presenters, Dr. Neha and Dr. Honeshwari, who are our third year postgrad students. I hope they'll come out with a good presentation and make this nice scientific event. Over to Neha and Dr. Honeshwari. They can start the session now.
Yes. Good evening, everyone. My name is Dr. T.G. Neha Sunil, and this is Dr. Honeshwari Suresh. We are junior residents in the Department of Anesthesiology, JN Medical College, Belgavi, Karnataka. I would like to thank Dr. Rajesh Mane sir and Dr. Manjunath C. Patil sir for guiding us through this presentation. And I would also like to thank ISA National for giving us this opportunity. The seminar topic under discussion today is anesthetic and intensive care management of patients with sepsis and septic shock. It will be discussed under the following headings of shock overview, septic shock, etiology, pathophysiology, surviving sepsis campaign, anesthetic management, goals of care, and summary. Coming to shock, shock is a clinical syndrome of acute circulatory failure resulting in poor tissue perfusion and impaired cellular metabolism. It can be characterized with mean arterial pressures of less than or equal to 60 millimeters of mercury, systolic blood pressure of less than or equal to 90 millimeters mercury, reduced urine output, altered mentation, metabolic acidosis, and elevated serum lactates. Now, shock can be divided broadly into 4 types. Coming to cardiogenic shock and obstructive shock, here the major dysfunction is at the level of the heart. In cardiogenic shock, it is the pump itself that does not work because of myocardial infarction or cardiomyopathies or carditis, whereas in obstructive shock, it is a mechanical obstruction that can result from tension pneumothorax, cardiac tamponade, or restrictive pericarditis. In both of these, the cardiac output is reduced, and as a compensation, systemic vascular resistance increases, and the preload, which is indicated by central venous pressure and pulmonary capillary wedge pressure is increased. In hypovolemic shock, it is the intravascular volume that is depleted, so the cardiac output is reduced. As a compensation, this systemic vascular resistance is increased, and the preload is decreased, which is shown by pulmonary capillary wedge pressure and central venous pressure. In distributive shock, it comes under hyperdynamic type of shock. It is odd from these 3 because the systemic vascular resistance is increasing, and the preload will decrease and cardiac output is also decreased. These are the hemodynamic changes that are seen in various types of shocks. Now, coming to the clinical differences, the extremities in obstructive shock will be warm. The extremities in distributive shock will be warm because there is global vasodilation, whereas in cardiogenic shock and hypovolemic shock, it's cold because of vasoconstriction, peripheral vasoconstriction that is present. The jugular venous pressure is high in cardiogenic and it's less in hypovolemic and distributive type of shock. And the hypovolemic and distributive kind of shock are respond to fluid They respond to fluid administration, as we can see on USG with IVC diameters of less than 2.1 and increased collapsibility of more than 50%. And even on passive leg raise, there will be response in hypovolemic shock and distributive kind of shock. But where in cardiogenic shock, you won't be seeing this response. Now, coming to septic shock, sepsis and septic shock definition. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. The organ dysfunction is defined as an acute change in the total SOFA and total sequential organ failure assessment score of 2 points or greater due to underlying infection. I'm so sorry, 1 second. Yeah. Due to underlying infection. Now, coming to septic shocks, it includes sepsis with persistent hypotension of systolic blood pressure less than 90 millimeters of mercury for at least an hour despite adequate fluid resuscitation, or requiring vasopressors to maintain mean arterial pressure of more than or equal to 65 millimeters of mercury with a serum lactate levels above 2 millimoles per liter despite adequate fluid resuscitation. The SOFA score, that is the sequential organ failure assessment score, assesses 5 organs with a score of 0 to 4. In cardiovascular system, we'll be looking at blood pressures, the mean arterial pressures, whether vasopressors are being used or no. In central nervous system, we look at the Glasgow Coma Scale. In respiratory system, we look at PaO2 and FiO2 ratio. In coagulation, we look at the platelets. In liver, we look for bilirubin, and in kidney, we look for creatinine levels. An increase in number of points achieved through this score is showing the mortality as depicted in the graph. The SIRS criteria, that is systemic inflammatory response criteria, which was previously used, is abandoned, and but the following parameters are under it: temperature, heart rate, tachypnea, and white blood cell counts. The quick SOFA score, which has the parameters of altered mental status, GCS less than 15, tachypnea, a respiratory rate more than 22, and hypotension, which systolic blood pressure of less than or equal to 100 mmHg. Here, 2 or more points indicated high risk of poor outcome. The latest guidelines recommend against using the quick SOFA compared to SIRS, MUSE, and MUSE as a single screening tool for sepsis or septic shock. However, it can still be used as a predictor of poor outcome, but the clinician should have in mind that for predicting mortality, quick SOFA has low sensitivity and moderate specificity. So it should also always be used as an adjunct to other scores. Now, these are the 4 stages that you can see in sepsis and septic shock. First stage will be the infection, then sepsis, septic shock as defined before, and the last will be MODS. And again, multiple organ dysfunction syndrome is no longer in use. Coming to the etiology, the sources of these infection can come from the respiratory tract or the pulmonary parenchyma, the urinary system, the abdomen, pyrexia of unknown origin, or others. They can be from gram-positive bacteria like Staphylococcus aureus, Streptococcus pneumonia, pneumococcus, or gram-negative organisms like E. coli, Klebsiella species, Pseudomonas aeruginosa, or could be of fungal origin. Coming to the pathophysiology of septic shock. Now, the endotoxins of the bacterium directly damage the endothelial tissue, which the host responds by activating neutrophils, monocytes, and complement system with release of tissue necrosing factor, interleukin-1, interleukin-6, interleukin-8, nitric oxide, and reactive oxygen species. Now, the endothelium is a functional unit which contains glycocalyx, which is made up of glycoproteins and proteoglycans. This glycocalyx forms a mechanical barrier that regulates vascular permeability. The activation, it plays a role in activation of leukocytes and platelet adhesion and modulation of inflammatory and anti-inflammatory response. Damage to this, which is called as glycocalyx shedding by oxidizing agents, cytokines, exotoxins, cause increased vascular permeability with the production of edema. Along with this, there is the procoagulant Along with this, the procoagulant and the antifibrinolytic processes are taking place simultaneously. And there is also an anti-inflammatory mediators like interleukin-10. I'm sorry, sir, is there an error in display?
Yeah, actually, it is showing the presenter's view. Can you go to the slideshow? It is showing the presenter's view. Your view is coming.
All right, 1 second, ma'am.
Yes, this is better. Now here you can go to slideshow.
Yes, ma'am.
Okay, correct.
Okay, ma'am. Coming to the pathophysiology. This. Okay, coming to the pathophysiology, like I've explained, due to glycocalyx shedding, there will be increased vascular permeability and there'll be increased vascular permeability and development of edema, which further damages the tissue perfusion. Further damages the tissue perfusion. Now, this will be the hemodynamic alteration that you will see in septic shock. Because of increased nitric oxide that is in vascular endothelial cells, there will be vasodilation in arterial and veins, decreasing the ventricular preload and afterload, and and in addition to this, there is oxidant injury, which is and which leads to fluid extravasation and hypovolemia. Initially, the pro-inflammatory cytokines do promote cardiac dysfunction, but as a result of tachycardia and volume resuscitation, cardiac output is still maintained. So you'll see a typical pattern of low CVP, high cardiac output, and low systemic vascular resistance. This manifests in the organ systems as cerebral dysregulation. There's sepsis-induced delirium, poor GCS will be seen. The febrile responses are seen as fever. In renal system, acute kidney injury will manifest as oliguria and anuria. The vasodilatory and capillary leak that happens in the pulmonary system will lead to acute lung injury and result in acute respiratory distress syndrome. Initially, the compensation that is offered by heart is no longer there. There is biventricular dysfunction where cardiac contractility is compromised and hemodynamic collapse is seen, leading to shock. The poor hepatic function, in addition to the ongoing coagulopathy, will increase the amount of coagulopathy, and complement and coagulation activation will lead to consumption coagulopathy, DIC, ultimately leading to sepsis and septic shock. Now, Surviving Sepsis Campaign, International Guidelines for Management of Sepsis and Septic Shock, 2021. It was intended to provide guidance for the clinician caring for adult patients with sepsis or septic shock in the hospital setting. Now, the 1 hour bundle, the targets that need to be achieved in the very first hour that the patient presents is the first is to measure lactate and remeasure lactate if the initial lactate was elevated above 2 millimoles per liter, to obtain blood cultures before administering antibiotics. This has to be done at 2 different sites. Administer broad spectrum antibiotics and begin rapid administration of 30 ml per kg crystalloids for hypotension or lactate more than 4 millimoles per liter. Apply vasopressors if hypotensive during or after fluid resuscitation to maintain a mean arterial pressure of more than equal to 65 millimeters of mercury. Now, septic shock and sepsis and septic shock are medical emergencies. Their treatment and resuscitation has to begin immediately. 30 ml per kg of IV crystalloid fluids are recommended to be administered within the first 3 hours. Now, this evidence stems from observational studies, but there was a study that showed that failure to receive 30 ml per kg of IV crystalloids has resulted in have resulted in increased hospital mortality, ICU stay. The three trials of PROMISE, ARISE, and PROCESS have compared the early goal-directed therapy, standard care, and usual care, and they've come to the conclusion that there was no difference in mortality in these different patients. This again shows us that beyond, when the patient requires fluid beyond this 30 ml per kg in the after the first 3 hours, we have to use dynamic measures to guide fluid resuscitation over only physical parameter pressure to the left or right ventricle and poor prediction of volume responsiveness. The central venous pressure, pulmonary capillary wedge pressure, and collapsibility index, and diastolic and end systolic ventricular diameter. All these come under the static measures, whereas dynamic measures, which we are encouraged to use, are a combination of preload modifying maneuvers with measurement of its immediate hemodynamic response. So fluid challenge test, which can be done against cardiac output, stroke volume or pulse pressure, passive leg raise test, which can be done against cardiac output, stroke volume or pulse pressure variation, stroke volume variation, and echocardiography can be used. This is a picture depicting how passive leg raise test is done. The patient's legs are lifted at a 45-degree angle for about 60 to 90 seconds. This maneuver helps the blood that was pooled in the legs to come to the heart, which will be about 300 ml. And if there is an increase in cardiac output or stroke volume or increase in pulse pressure, after this 60 seconds after this maneuver is done, that means the patient will be fluid responsive. If monitoring parameters like cardiac output and stroke volume are not available, or initially when the patient comes to us, we don't have a central line in place, we can use pulse pressure as a target. Increase in pulse pressure of more than 15% can show that the patient is fluid responsive. In settings where advanced hemodynamic parameters are not available, we can use skin temperatures, we can use temperature, skin mottling, and capillary refill time to guide our resuscitation as an adjunct to others. In the trial Andromeda Shock, they have compared the effect of resuscitation strategies targeting peripheral perfusion status versus serum lactate. And on the third day, they found that the outcome was better in the group where they've used capillary refill time compared to serum lactate, and the mortality was also less in the group with capillary refill time. However, the mortality was not significant. The decrease in mortality was not significant, but because of its easy bedside procedure, it being a bedside procedure, easily performed, and it costs nothing, they have recommended that we use this as an adjunct to others. Now coming to the lactate levels. The lactate levels do not directly measure tissue perfusion, but they are a surrogate for tissue hypoxia. Lactate levels are used both for defining shock and for guiding fluid resuscitation. In the RCTs, significant reduction was found in mortality when lactate-guided resuscitation was initiated. Now, it has to be kept in mind, however, that lactate increases not only because of tissue hypoxia, but it can also be due to decreased hepatic clearance, increased muscle ATPase activity, decreased pyruvate dehydrogenase activity, cell mitochondrial dysfunction, and adrenaline infusion. And also, a normal lactate does not exclude regional hypoperfusion. So the clinician has to bear that in mind. For adults with septic shock on vasopressors, initial target mean arterial pressure of 65 millimeters of mercury over higher mean arterial pressure targets are recommended. There were trials which did compare targets of 65 to 75 to 80 to 85, and they found there's no difference in mortality. And there are trials where elderly 65 years and above age group was given permissive hypertension with the MAP target of 60 mmHg and found that there's no harm. Since there's no advantage with higher values and there's no harm with a value of 60, they've recommended that we use 65 mmHg as a target.
So coming to the diagnosis, microbiologic cultures to be obtained before starting antimicrobial therapy. We have to obtain cultures from 2 different sites, and we can also obtain cultures for CSF, or we can obtain cultures of urine as well, based on the presentation of the patient and the severity of the infection. At least 2 sets of blood cultures for aerobic and anaerobic is collected. Antimicrobial therapy. IV antimicrobials be initiated soon as within 1 hour of diagnosing septic shock. Empiric broad spectrum antibiotic therapy with one or more antimicrobials which cover all likely pathogens. Empiric antimicrobials therapy to be narrowed once pathogen is identified and sensitivities are established and or adequate clinical improvement is noted. So coming to the recommendation against sustained systemic antimicrobial prophylaxis in patients with severe inflammatory states of non-infectious origin, like acute pancreatitis and burns infections. So we recommend that the IV antibiotic infusion is started. A continuous infusion is preferred over intermittent infusion. And we start off by giving a loading dose followed by the continuous infusion. Coming to empiric combination is aimed for most likely bacterial pathogen for the initial management based on the demography and based on the patient's symptoms, the location of the infection and the severity. Recommendation against combination therapy for routine treatment of neutropenic sepsis or bacteremia. De-escalation with discontinuation of combination therapy within the first few days of clinical improvement. So duration of antimicrobial therapy of 7 to 10 days. A shorter duration with rapid clinical resolution following effective source control, and a longer duration is seen with patients with slow clinical response, undrainable foci of infection, and bacteremia with Staph aureus or fungal and viral infections or immunologic deficiencies, including neutropenia. So coming to daily assessment for de-escalation of antimicrobial therapy has to be done. Procalcitonin levels are not used to initiate antimicrobial therapy, but they are used to assess if the cause is infectious or non-infectious, or to assess the progression of the antimicrobial therapy that we're giving, and to stop antimicrobial therapy. So use of empiric antifungal therapy in patients at high risk of fungal infection is also recommended. So coming to source control, a specific anatomic diagnosis of infection requiring emergent source control to be identified and excluded, and it has to be minimally invasive. Prompt removal of intravascular access devices, which are a possible source of sepsis or septic infection, has to be done after another source is established. Fluid therapy. A fluid challenge technique to be applied where fluid administration is continued as long as hemodynamic factors continue to improve. So here we see vasoplegia which is seen in distributive shock, which has to be treated with fluid therapy. And the choice of fluid is balanced crystalloids like RL over saline, NS, because NS has a risk of hyperchloremic metabolic acidosis. Hence, crystalloids are preferred. Coming to the use of albumin, in addition to crystalloids for initial resuscitation and subsequent intravascular volume replacement in patients with sepsis and septic shock, when patients require substantial amounts of crystalloids. Only after we have, if we are not able to achieve a MAP of more than 65, after administering adequate fluid and adequate vasopressors, still we are not able to achieve adequate mean arterial pressure, then albumin administration is done, and we can maintain it at a level of 30 grams per liter. Recommendation against use of head starch for intravascular volume replacement, and this is because head starch has a high molecular weight, and because of this, the need for renal replacement therapy is seen to be higher, and using crystalloids over gelatins when resuscitating patients with sepsis or septic shock. So crystalloids are also not preferred for resuscitation. So coming to vasoactive mediators, We see that there is loss of vasomotor tone and systemic vasodilation and hypotension. So we use vasomediators to improve tissue perfusion and oxygenation. So here we have to set up an arterial cannula for arterial pressure and beat-to-beat analysis. So norepinephrine, the site of action is alpha-1 and beta-1. We give it at a dose of 0.1 to 1.2 micrograms per kg per minute, and it is given through IV infusion. It is the vasopressor of choice in septic shock. Potent vasoconstrictor, it increases SBP and DBP. Activates baroreceptor system, so we can also see bradycardia in this. The adverse reactions include intense vasoconstriction with organ ischemia and necrosis and arrhythmias. So coming to vasopressin, vasopressin acts on V1 receptors which are present on the blood vessels and V2 receptors present on the kidneys. And it is administered at a rate of 0.25 to 0.5. And it is used for septic shock. It causes relative vasopressin deficiency. In the first 24 to 48 hours, it is seen that vasopressin is increased, following which there is a decrease in vasopressin, and this is called relative vasopressin deficiency, which causes hypotension. And it is also, vasopressin is used as an add-on to noradrenaline, and it also decreases the need or the dose of noradrenaline that we are administering. Coming to the adverse reactions, increased liver enzymes, reduced platelet count, and extravasation causing skin necrosis. And it also increases the BP and SVR. Dobutamine. The dose of dobutamine is 5 to 20 micrograms per kg per minute. It acts on beta-1 and beta-2 receptors. It increases the contractility and the heart rate, improves the cardiac output. The BP remains unchanged. It is a directly acting synthetic catecholamine. It is used when there is cardiac decompensation. When oxygen extraction is low and states of reduced cardiac output and sepsis, we start the use of dobutamine. It can be administered when central venous oxygen saturation is less than 65%, and increased myocardial oxygen demand and hypotension arrhythmias are the adverse reactions. And it is contraindicated in dynamic intravascular obstruction, like HOCM and left ventricular hypertrophy. Coming to epinephrine, it acts on alpha-1, alpha-2, beta-1 and 2 receptors. It is a naturally occurring catecholamine, and it is administered at a dose of 0.01 to 0.5 micrograms per kg per minute. Based on the alpha-1 action, it causes vasoconstriction and systemic vascular resistance, and beta-1 action causes increased heart rate and inotropy, elevated concentration of glucose, and it increases the concentration of lactate. So we can see hyperlactemia in epinephrine administration. So dopamine. Dopamine is an endogenous catecholamine. It is a precursor of norepinephrine, and the side effects include tachyarrhythmias, and it can also cause bradycardia. Hence, its use is decreased now, and it is also dose dependent. So on lower doses of 3 to 5, it acts only on dopaminergic receptors, causing a fall in BP. On higher doses of 5 to 10 or 10 to 20, it acts on alpha-1 and beta-1, causing positive inotropic conotopic effect, and increased in SVR, and the venous return is also increased. So coming to the use of corticosteroids. Corticosteroid use, we administer IV hydrocortisone in use of IV hydrocortisone is not recommended for sepsis patients if fluid resuscitation and vasopressor therapy have restored hemodynamic stability. But if again BP is not being maintained, then we can start IV hydrocortisone. We administer about 200 milligram per day, and it can either be given as divided doses of 50 mg, or we can also give it as an infusion. It is also advised to start this 4 hours after starting any inotropes. Blood products, PCV transfusion, hemoglobin concentration decreases to we start a PCV transfusion only when hemoglobin concentration is less than 7 gram per deciliter in adults in the absence of accentuating circumstances such as myocardial ischemia or severe hypoxemia or acute hemorrhage. Recommendation against the use of erythropoietin for the treatment of anemia. Fresh frozen plasma is used to correct clotting abnormalities only in the presence of bleeding or any invasive procedures. So coming to prophylactic platelet transfusion. We give platelet transfusion only when there is platelet count is less than 10,000 and transfusion is done in the absence of any apparent bleeding. Less than 20,000, transfusion with significant risk of bleeding, and more than 50,000 transfusion advised for active bleeding or surgery or invasive procedures. Immunoglobulin therapy is not recommended according to the latest guidelines. Anticoagulants, use of antithrombin is not recommended. Thrombomodulin or heparin is not advised. Coming to mechanical ventilation, target tidal volume, we provide lung protective ventilation. So target tidal volume of 6 ml per kg of predicted body weight is administered. The upper limit for plateau pressures is 30 centimeters of water, and use of higher PEEP over lower PEEP in adult patients with sepsis-induced moderate to severe ARDS is given. We also use lung recruitment maneuvers. So basically, we increase the transthoracic pressure by increasing the expiratory end volume, and this opens up, this recruits all the alveoli that are collapsed. So this helps the patient with better oxygenation. Prone over supine position in adult patients with sepsis-induced ARDS with PaO2 by FiO2 ratio of less than 50. So this is also advised in a duration of 12 hours. We put the patient in prone position for a duration of 12 hours. No recommendation regarding the use of non-invasive ventilation for patients with sepsis-induced ARDS. Use of neuromuscular blocking agents for less than 48 hours in adult patients with sepsis-induced ARDS and PaO2 by FiO2 ratio less than 150 millimeters of mercury. Use of conservative fluid strategy for patients with established sepsis-induced ARDS who do not have evidence of tissue hypoperfusion. There's also recommendation against the use of beta-2 agonist for the treatment of sepsis-induced ARDS without bronchospasm. Recommendation against the routine use of PA catheter and use of lower tidal volumes over higher tidal volumes for patients with induced respiratory failure. Mechanically ventilated sepsis patients to be maintained with the head of the bed elevated between 30 to 45 degrees to limit aspiration risk and prevent the development of ventilator associated pneumonia. Using spontaneous breathing trials in mechanically ventilated patients with sepsis who are ready for weaning is recommended. Recommendation for the use of weaning protocol in mechanically ventilated patients with sepsis-induced respiratory failure who can tolerate weaning. Sedation and analgesia. Continuous or intermittent sedation should be minimized in mechanically ventilated sepsis patients, targeting specific titration endpoints. Glucose control. We have to maintain an glucose level of between 140 to 180. If it is more than 180 milligrams per DL on 2 consecutive blood glucose levels, then we start an insulin infusion. The blood glucose value to be monitored every 1 to 2 hours until glucose values and insulin infusion rates are stable. Then every 4 hours thereafter in patients receiving insulin infusion. Glucose levels to be obtained with point-of-care testing of capillary blood. But if we have an arterial catheter access, then we can collect blood from there. So coming to renal replacement therapy, either continuous or intermittent renal replacement therapy to be used in patients with sepsis and acute kidney injury. The use of continuous renal replacement therapy to facilitate management of patients who are hemodynamically unstable. Suggestion against the use of renal replacement therapy in patients with sepsis and acute kidney injury for increase in creat or oliguria without other definitive indications for dialysis like electrolyte imbalance, etc. Bicarbonate therapy. Recommendation against the use of sodium bicarbonate therapy except when the value of pH is less than 7.1 and bicarbonate value is less than 5 milliequivalents per dl. Venous thromboembolism prophylaxis. Pharmacologic prophylaxis with unfractioned heparin or low molecular weight heparin is used. Low molecular weight heparin is used rather than unfractioned for venous thromboembolism prophylaxis in the absence of contraindications for the same. So combination of pharmacologic and mechanical prophylaxis is preferred. Mechanical venous thromboembolism is preferred when pharmacologic is contraindicated. Coming to stress ulcer prophylaxis. Stress ulcer prophylaxis given to patients with risk of sepsis or septic risk factors for GI bleed. Use of either proton pump inhibitors or histamine 2 receptor antagonists when stress ulcer prophylaxis is indicated. Stress ulcer prophylaxis in patients without risk factors for GI bleed is not recommended. Nutrition, enteral feeds are preferred over parenteral feeds. And we initiate IV glucose over the first 7 days in critically ill patients with sepsis or septic shock, for whom early enteral feeds are not feasible. We can start enteral feeds only after the lactates have come under control, and preferably after 72 hours. Early trophic or hypocaloric or early full enteral feeding in critically ill patients with sepsis or septic shock is advised. If trophic or hypocaloric feeding is the initial strategy, then feeds should be advanced according to patient tolerance. The use of omega-3 fatty acids for immune supplementation is no longer recommended, and routine monitoring of gastric residual volumes in critically ill patients is not recommended, but gastric residual measures is recommended in patients with a high risk of aspiration. Use of prokinetic agents in critically ill patients with sepsis or septic shock and feeding intolerance is done. Post-pyloric feeding tubes is in critically ill patients with sepsis or septic shock with feeding intolerance or who are considered to be high risk for aspiration. Use of IV selenium, arginine, glutamine, and carnitine are no longer recommended.
Coming to the anesthetic management can, the preoperative can be done under three headings: preoperative optimization, intraoperative considerations and concerns, and postoperative handoffs. Coming to the preoperative optimization, this has to be initiated before, this has to be initiated before induction of anesthesia and continued during the surgery. Then fluid resuscitation, as we have discussed before, 30 ml per kg body weight fluid should be administered in the first 3 hours, and further fluid should be based on dynamic fluid responses and addition of vasopressors within the first hour. While we are resuscitating the patient, if the etiology of the shock is still unknown, we can do cardiac function assessment to identify septic cardiomyopathy if there is any, and we can also use echocardiography or biomarkers to come to conclusions for the same. And we have to maintain, if we are taking the patient up for surgery, we have to maintain the hemoglobin levels of between 7 to 9 grams per deciliter. Now, coming to the intraoperative management, the monitors that are used for this patient will be of importance. The standard monitors that we use, which is a ECG, non-invasive, blood pressure, SpO2, the ETCO2, then invasive blood pressure monitoring and central venous catheters. However, these days the pulmonary artery catheterization and central venous pressure are not used anymore. We look for more non-invasive means of monitoring the patient. Arterial lines can also be placed. For induction, we need to consider that the patient is already in hypotension, and using induction agent of any sort might aggravate that hypotension because of sympathetic inhibition. So our induction agents of choice would be ketamine or ketamine, and etomidate can also be used. Now with ketamine, it is a sympathomimetic, but it causes negative inotropic. It does have a negative inotropic action. Its sympathomimetic action might be blunted in an ICU patient as they are catecholamine deficit. But ketamine also, in addition to this, it also has bronchodilatory action. It also has immunomodulatory action. So it still remains to be induction agent of choice. Etomidate can also be used, which won't cause much changes in the hypotension and cardiac contractility. However, because of its side effect of adrenal suppression, its use is its use can come with certain concerns. However, but even if the adrenal suppression does present, we can manage it by infusing IV steroids over the period of 24 to 48 hours where it lasts. Now, for induction itself, we consider this an emergency, and the patients might also have ileus, so we consider a patient in sepsis or septic shock a full full stomach patients. So we will go for rapid sequence induction. For the use of opioids, remifentanil is preferred over fentanyl because it's can be metabolized by non-specific esterases. Then for muscle relaxants, benzyl isoquinoline compounds are preferred, like atracurium, cisatracurium are preferred over aminosteroid compounds like vecuronium and rocuronium. For airway management, ET tubes of appropriate size, we use again lung protective ventilation of 6 ml per kg tidal volume with high PEEP around 8 to 10 centimeters of water. Then fluid, blood, and blood product management, as we have discussed earlier, balanced crystalloid at 30 ml per kg. Trigger for blood transfusion will be hemoglobin less than 7 grams per DL and platelets less than 50,000, and vasopressors as and when required. Now coming to the OR and ICU transition and handoff, we have to, monitoring and support patient history, resuscitation trends, and follow-up items need to be discussed with the intensivist that you're handing off the patient to. Now, the monitors that were used intraoperatively, the airway lines and tubes, intraoperative ventilator settings, current continuous infusion of fluid therapy, surgical drains, and instructions for management should be done. The patient history, all the medical history, the specific risk factors that may challenge resuscitation, the history of present illness, including current suspected infectious source, surgery performed, important OR events and findings such as airway complication, bleeding, contamination, event perforations, all this have to be discussed. Resuscitation trends of fluid, what was the fluid responsiveness of this patient, what were the vasopressors administered, what were the targets of resuscitation, using mean arterial pressure, central venous pressure, lactate urine output, and focus relevant trends in laboratory data have to be told in the handoff, and follow-up items such as time-sensitive and elements, antibiotic dosing, microbiologic culture, anticipated cause for hemodynamic instability need to be discussed. Now, setting goals of care, the goals of care and prognosis to be discussed with the patient and family. The goal of care be incorporated into treatment and end-of-life care planning, utilizing palliative care principles are appropriate. The goals of care can be addressed as early as feasible, but no later than within 72 hours of ICU admission. Now, as discussed above, these are the pillars of treatment that come in patient with sepsis and septic shock: the antimicrobials, the time of initiation of antimicrobials, and the coverage that we use, the fluids, the initiation of fluids, the amount of fluids, and to see if the patient is fluid tolerant and fluid responsive. Vasoactive agents, early initiation of vasoactive agent in case the mean arterial pressures are not picking up, and adding agents like vasopressin if required, and changing their doses, and oxygenation and ventilation of the patient, and other treatments. All these come under the pillars of treatment with in a patient with sepsis and septic shock. Now, to give a brief summary, the patient has come for triage or ICU. We look for airway, breathing, and circulation, while simultaneously we assess for blood pressure, fluid resuscitation, vasopressor, inotrope, and collection of blood. If the patient is conscious, if yes, does not necessitate securing of airway. If no, then necessitates securing airway surgery. If yes, then initiate or continue the first star bundle, shift for damage control surgery, and continue the first star bundle, invasive monitoring, administer antibiotics, titrate anesthetics, then arterial blood gas analysis, and shift to ICU. Whereas if patient does not require surgery, we will shift the patient to the ICU, complete the first star bundle, the same invasive monitor, dynamic variables, focus, and continue or change antibiotic, lung protective ventilation, early proning, procalcitonin, lactate monitoring, and antibiotic de-escalation will be done. These are our references. Thank you. Stop short.
Yeah. Hello, Neha.
Yes, sir.
When do you take up these cases for surgery, definitive surgery?
So when we want to do, despite antibiotic administration, if we don't control the source of infection, then the patient will only deteriorate. So when they come for source control procedures like amputation or debridement of necrotizing fasciitis or removing pockets of pus from either the abdomen or the thorax or the brain, then we go for definitive surgery, sir, because it will be under emergency conditions, and unless you control these, the patient will not improve.
Yeah, because there was one question, which will be your first preventive step, early intervention or damage control?
Sir, first stabilizing the patient is important, sir. So following the first hour bundle by administrating broad spectrum antibiotics, fluid therapy, and if vasopressor need is required, starting them off to maintain mean arterial pressure of more than 65 is advised. After we stabilize the patient, then we can take the patient for a surgical procedure. If we are not able to control the source of infection with a minimally invasive like procedure like aspiration or ultrasound guided aspiration and things like that, then we can go in for surgical procedures.
Because these patients are very at the edge. Suppose you start inducing them with anesthetic drugs, they suddenly collapse, and they just don't come out of that collapse if it occurs after your induction. So stabilization is really required. Okay, another question was, what is the maximum dose of noradrenaline?
So for noradrenaline, we can go up to 3.5 mics per kg, sir, if the mean arterial pressures are not picking up. However, beyond this point, if they don't pick up, then we can add vasopressin in addition to it. Adding vasopressin will help decrease the noradrenaline dose that is being consumed, and will also help in increasing the mean arterial pressures.
So one question in the chat box, how to manage sepsis developing intra-op, especially in urology patients?
Sir, sepsis intra-op, we can, after stabilization of the patient, we'll have to assess what the problem is. We can send blood cultures and urine cultures before starting empiric antibiotic therapy, followed by the start of fluid resuscitation and vasopressor therapy. And on taking up the patient for OT, we can induce the patient with ketamine or etomidate, which is the preferred induction agent of choice, which doesn't decrease the pressures of the patient. Monitoring is very important. Invasive arterial monitoring for cardiac output and blood pressure monitoring is has to be done.
So irrespective of where we encounter sepsis in a patient, it can be at the ICU or before we take the patient up for surgery or intra-op, the same guidelines can be followed. So for if the patient does develop sepsis intraoperatively, we can assess the patient organ function using the sequential organ failure assessment score, and go ahead with our first star bundle where we collect blood samples, administer antibiotics, because at this point we don't know what they're sensitive to. We will start empiric antibiotics. We will measure the lactates. We will try to stabilize the BP as per the protocol with mapped targets of 65 millimeters of mercury, and we will add vasopressors if required. So our protocol will remain the same irrespective of where we encounter the patient.
Coming to muscle relaxants, which one you advise?
Atracurium and Cisatrap. Sir, atracurium is advised because it is metabolized through Hoffman's reaction. Vecuronium tends to have a negative impact on the renal system. So preferred is Atra and Cisatra. And
But atracurium in case of failure, it can have that side effect of laudanum release now, which can have a
Yes, sir. Yes, sir. So in that case, cis atracurium, which does not have the side effect of histamine release, can be used. It's preferred over atra, but otherwise, this class of drugs are preferred over aminosteroid drugs, which are vecuronium, rocuronium, sir.
Yeah, cis atracurium is preferable. Okay.
Yes.
Else. Okay. So as I said, as you said, there are pillars in resuscitation of patients in shock. Not only
Yes.
your restoration of intravenous compartment, but also proper antimicrobial therapy and source control. Okay. So source control is required. Without the source control, without you, for example, if it's a urology case, without draining the pus, if at all is present, patient may not improve. Okay. What about steroids?
So steroid therapy again, they've told that if we are administering steroids, we only administer if our fluid therapy and vasopressor are not able to manage the pressures of the patient. But if then we start hydrocort at a dose of 200 mg per day, sir. We can either give infusion doses or we can give 50 mg at 4 different times. But it's also recommended in a few studies that if we have started vasopressors, 4 hours after starting vasopressor, it's recommended to start hydrocortisone, sir.
So it'll have both the anti-inflammatory effect and it will also sensitize the heart to the effect of catecholamine. So it will magnify our vasopressor effect. So in both ways, it is beneficial.
What about septic cardiomyopathy? What is the role of fluids in septic cardiomyopathy?
Sir, in septic cardiomyopathies is development of ventricular systolic or diastolic dysfunction which is not associated with ischemia, sir. This happens in a later stage of septic shock. In these patients, fluid and vasopressors alone might not help improve the circulation. So we can add an inotrope like dobutamine to help with cardiac contractility.
Okay. Now, for example, if patient, you mentioned that 30 ml per kg, now.
Yes, sir.
What about in cardiomyopathies or patients with LV dysfunction?
So 30 ml per kg is not a set dose, sir. According to a few studies, it is an average we can give about 30 ml per kg of crystalloids. But if it is a patient with cardiomyopathy or any renal disease, then we can always decrease the amount of crystalloids that we're giving to 10 to 15 ml per kg. According to the patient's condition, we can optimize and titrate the amount of fluids that we're administering, sir.
Any role of other adjuvants like vitamin C or thiamine? Is there used?
Sir, according to the latest guidelines, the use of vitamin C, selenium, any anti-inflammatory, all these drugs are not recommended, sir. They have seen that there's no improvement in the mortality of the patients with sepsis or septic shock. So they've told against the use of vitamin C, selenium, arginine.
Regarding antibiotic coverage, you wait for the culture report to come. You don't wait actually, na? So which antibiotic to start?
So we start broad spectrum antibiotics, sir. We have to start antibiotics in the first hour of when the patient presents to the emergency department. If the patient presents with moderate or mild sepsis or suspicion of sepsis without any shock, we can wait up till 3 hours and assess the patient, do a rapid assessment in terms of clinical evaluation. And we can also send out investigations to start antibiotic therapy within the first 3 hours, sir. And coming to antibiotics, we start a broad spectrum antibiotic according to the demography of the place they are from, and the most common pathogen or the antibiotic resistance that is prevailing in that particular region. And we can also start MRSA coverage if the patient has had is been MRSA positive in the past 1 year, or if there is antibiotic administration in the past 30 days. If there are any indwelling catheters, any skin infections in them, we start MRSA coverage. And antifungals, also if the patient is neutropenic, immunosuppressed patients, we start antifungal agents, sir.
So preferably you start piperacillin, tazobactam or meropenem.
Yes, sir.
Huh?
For MRSA, vancomycin is preferred.
Sometimes, as you said, it goes along with the institutional guidelines also.
Yes.
Any word on pediatric patients?
So these guidelines are majorly applicable to adults. So for pediatric.
So this Septic guidelines have not come out for pediatric as such.
Yes, sir.
Among crystalloids, which one you prefer?
Sir, ringer lactate is the preferred crystalloid, sir, over 0.9% NS, because it is a balanced fluid, and NS has more deleterious effects like hyperchloremic metabolic acidosis, which causes renal vasoconstriction. It causes decrease in GFR and increased perfusion of gastric mucosa. So we don't use NS. And it is also seen in a few studies, it's seen that patients treated with RL had a better prognosis, and mortality has been decreased.
Regarding role of albumin, some studies have mentioned albumin, but what do the recent guidelines say?
Sir, according to albumin is the only colloid that they've that the use is suggested for. Again, if we are not able to maintain the mean arterial pressure of the patient with fluids and vasopressors, it is advised to start albumin, and we have to either 20% or 4% albumin is administered, and we have to maintain a level of 30 grams per liter, sir. And it also increases the oncotic pressure, so it is the colloid that is preferred.
Any specific recommendation for pregnant patients?
So pregnant patients, for ventilation, sir, it's a relative contraindication for lung recruitment maneuvers and for prone ventilation. Apart from that, treating the source of apart from that, resuscitating the patient in the first hour is the same. And we also have to consider antibiotic therapy and source removal in these patients.
The only specific recommendation that given for pregnant women is ventilatory strategies. So apart from that, rest all we follow the same guidelines.
Yeah, take it. Another question is on antibiotic guidelines for neutropenic patients.
Sir, for neutropenic, again, we can start off broad spectrum antibiotics with piperacillin, tazobactam. And if the patient has MRSA resistance, we can add meropenem or vancomycin. And the use of antifungals is also recommended, sir, in neutropenic patients.
Okay. Most of it, I think I've covered questions. Maintenance of anesthesia.
So for maintenance of anesthesia, we again the patients will be more sensitive to they'll be more sensitive to inhibition by anesthetic agents. And even the minimum alveolar concentration in these patients is decreased. So titrated doses of induction agents should be used, titration to effect, and even inhalational agents can be used for maintenance of anesthesia. They are not a contraindication, but at the same time, it depends on the hemodynamics of the patient. The minimum alveolar concentration values are reduced, and it has to go according to the hemodynamic parameters of the patient.
Yeah, absolutely.
Sir, another point on pregnant women, sir. Since if the patient has come for delivery, term patient, then we can induce the patient with rapid sequence intubation rather than going in with regional anesthesia that we generally give to maintain the hemodynamics of the patient.
Mannitol, any role for mannitol?
So nothing according to the recommendations.
No, so no role for mannitol or colloids even they've suggested.
Cytosort therapy. Dr. Aditya.
So there's no specific guideline on cytosort therapy, so we are not aware of any such thing.
Okay. Among the induction agents, ketamine, etomidate.
Yes, so ketamine and etomidate. So propofol, they have conducted a study where they have compared the direct effect of induction agent on the cardiac dysfunction. So maximum dysfunction was seen with propofol, followed by midazolam if it was used for induction, followed by etomidate and ketamine. For etomidate, I think it was about 15 to 19%. With ketamine, it was only 6%. So there are studies that show that ketamine had a better outcome than etomidate, and there are studies that show the opposite. But with etomidate, again, there is the adrenal side effect of adrenal suppression, and the patients in septic shock in the pathophysiology, because of their anti-inflammatory responses, there will already be adrenal suppression in these patients. So because of the fear of excessive this thing, they choose ketamine over etomidate. But even if the patient does go in practical in studies where they studied etomidate as an induction agent in patients with septic and septic shock, they showed that there was no increase in immediate mortality with patients where etomidate was used. And the adrenal suppression that does happen with it can be treated with IV infusion of steroids.
During the intraoperative period, what really you look into actually? What all things you monitor? How well you monitor? What are the parameters you look at, and which can guide you in the hemodynamic management?
Sir, intraoperatively so again with induction, there is higher chances of, immediately after induction, there are higher chances of hypotension. So that has to be looked after. We can, we can use our standard monitors. In addition to the standard monitors, we can use an arterial line. Arterial line will also, in addition to giving us beat to beat variation of BP, it will also, it can also help giving pulse pressure variation. And if cardiac output monitors are used, then stroke volume variation can also be used. Previously, they did advise pulmonary artery catheterization and measurement of CVP, but because of invasive nature of these procedures, they are not as advised anymore. We can use other dynamic parameters. We for cardiac monitoring, we can use PICO, LITCO, and flow track. Flow track again does not require external calibration, so only an arterial line would be sufficient. That method can be used. Otherwise, if we are using pulmonary artery catheterization and CVP, the values can be used to assess if there is adequate hydration. If adequate hydration is achieved, then we can look into vasopressors for maintaining the BP.
So we can also check for mixed venous saturation and central venous oxygen saturations to see the perfusion of the patient, if the patient is still in a hypoperfused state.
And also, sir, in patients with septic shock, the major dysfunction, there is a discrepancy in tissue oxygenation, as in because of inhibition of mitochondrial utilization of oxygen, despite adequate oxygen being delivered, the cells are unable to utilize this. So here we again have to try preventing the shock before it goes into that stage. So the mixed venous oxygen saturation, which might show higher values, does not mean that the patient is utilizing this oxygen. Rather, it means that because the cells are unable to utilize this oxygen, its levels are high. And even the neutrophilic, even due to activation of neutrophils, oxygen consumption takes place. So that will also contribute to the values which are seen in mixed venous oxygen sample.
Okay. The main issue is perfusion with oxygen. Okay, you need to maintain a good perfusion. Okay, for that you need to have a good pressures plus the intravascular fluid. So you need to have a good functioning arterial line, so that which can help you guide your vasopressors, the fluids.
Yes.
Okay. So for fluid responsiveness, which one you suggest? Intraoperatively.
So starting with the simplest, we can do the capillary refill time, which can be seen at the nail bed, and sometimes when you can't see it in the nail bed, you can see it in the sternum. Next, for fluid responsiveness, we can see the difference in pulse pressure. So on giving a fluid bolus, if there is an improvement in pulse pressure by 15%, then the patient indicates that the patient is fluid responsive. Then going to the next level, we can use with an arterial line in place and a central venous catheter, we can go for cardiac output stroke volume monitoring. That is, when we give fluid bolus, there should be an increase in stroke volume by 10% and improvement in cardiac output. That means that the patient is fluid responsive. And you can also use central venous catheters, central venous pressure to see fluid responsiveness. If the central venous pressures are above 8, that means the patient is already adequately hydrated, and what they require is either vasopressors or inotropes.
One question on magnesium sulfate. Does it have any role?
Magnesium sulfate, according to the guidelines, nothing has been mentioned specifically on that side.
I don't think there's any specific indication for magnesium sulfate as such. When do you start nutrition?
Sir, nutrition, preferably we have to continue enteral nutrition, sir. It helps in maintaining the gut integrity and preventing prevents intestinal permeability and modulation of metabolic responses. And the effect of Clostridium difficile infections are also lesser. So preferred is enteral nutrition, but we have to start it. But we start it only after the lactate levels are under control, and there's no contraindication for enteral feeds. And another indication is we can start it within 72 after 72 hours, sir. It is preferred over parenteral nutrition. Parenteral nutrition is generally started after a week. Before starting enteral, we can give the patient IV glucose, sir, till the patient is ready to take in enteral feeds.
Always enteral nutrition is preferred over parenteral, but whenever there's a contraindication for enteral, how do you start parenteral? When do you start parenteral?
Sir, at least after a week of diagnosing, I think we start parenteral nutrition, sir.
Yeah. ठीक है. So patient has to be stabilized. No? Once the hemodynamics are stabilized, then you can start over any type of nutrition.
Yes.
Are there any specific contraindications for parenteral nutrition in these cases?
Extreme session. Sir, parenteral nutrition, there's a increased risk of infection, sir, through the catheter that we administer and intralipid and that is being administered through parenteral nutrition. So it is generally preferred later on if we are not able to maintain start enteral feeds or post-pyloric feeding.
Yeah. Yeah. Yes, ma'am. Okay.
All questions finished?
Almost all are covered.
Okay, sir. You must be having a look at the chat box, no?
Yeah.
There are one or two left. Can I ask them? One is the preferred inhalational agent if the patient undergoes surgery in sepsis.
Any inhalation agent you would like to use?
Negative. Sir, inhalational have negative. So they can decrease. It can cause a fall in blood pressure, sir. So judicious use of inhalational anesthetics has to be done.
The basic idea of using inhalation agent is to prevent awareness. Okay.
Awareness.
At the cost of, as you said, causing hemodynamic instability. Okay.
Yes, sir.
So it is just a benefit and risk at which you can use. If you want, you can use sevoflurane.
Yes.
Okay. What about ultrasound? Use of USG in management of shock?
So ultrasound, we can, when the patient has come to us, we can use to differentiate if the hemodynamics and the clinical symptoms, which usually don't give the etiology of the shock immediately. We can use ultrasound, so point of care ultrasound or rapid ultrasound in sepsis and hypotension can be used. We can use this ultrasound to look at our cardiac function. If the ventricular function is up, we can come in with 2D echo and IVC collapsibility. We can check if the biventricular function is intact, the valves are functioning fine, the cardiac output measurement can be done. We can see the IVC collapsibility. So this will, if there is any regional wall motion abnormality, if there is any of the cardiogenic etiology changes, we will get to know. And if there is any obstructive shock like cardiac tamponade or tension pneumothorax, also we can tell from the ultrasound. And IVC collapsibility will give us an idea about if the patient is fluid responsive or no. Where in cardiogenic shock, the fluid responsive is not there because the major pathology is in the pump, and whereas in hypovolemic and obstructive in distributive shock, the IVC diameter will be less and collapsibility will also be more than 50%. And we can also check the pleura. We can check for any bleed.
Yeah, it has a multi-faceted role actually, not only in diagnosis some of the conditions, but also, as you said, to know the fluid responsiveness.
And if our fluid, if the fluids that we're giving and if vasopressors are not acting, we can suspect a cardiac cause and assess the cardiac function with the help of ultrasounds.
Any role about angiotensin 2?
Sir, angiotensin 2 is produced because of activation of renin-angiotensin-aldosterone mechanism, sir. It is seen to increase the blood pressure, mean arterial pressures by 10 millimeters of mercury. They've recommended the use of angiotensin 2, but not as the first line drug. We can use it as if norepinephrine is used as the first line. After that, we can use this as an add-on drug.
Especially in severe shock where there's low cardiac output, it is not indicated.
Yes, sir.
What about any biomarkers for diagnosis of sepsis?
So procalcitonin is the one that is most commonly used to identify bacterial infection, to differentiate if it is bacterial or non-bacterial etiology, and also to stop the use or to assess the antimicrobial progression of the patient. Apart from this, we also use presepsin, sir. It is a new biomarker. It is more specific in identifying the progress of septic shock. Otherwise, we use the normal lactate levels to check for shocks, sir. More than 2 millimoles per liter is considered.
Yeah.
So initially, procalcitonin was used to initiate the antibiotic therapy. It was used to differentiate between infective and non-infective agents, but it is no longer recommended that you use it for initiation, but the values can be used for de-escalation of antibiotics. The presepsin, which is a newer molecule, it is an N-terminal molecule of CD14, but because of the higher costs, it's not in routine use.
And much research has not been able, we have not been able to do a lot of research in that biomarker.
One, I think this is the first time I'm here reading this. Trotricogen alpha. Trotricogen alpha. Any role of this?
So nothing mentioned in the
I'm not
guidelines.
aware of it. I think madam only should answer this. Yes.
You should have gone to IJ, Neha. It's written in IJ.
Yeah. Madam will explain, I think.
Shall I ask you one question? A good one, because you are already being appreciated by everyone, the way you are answering, well prepared, everything. I've got a doubt in my mind. Shall I go ahead?
Yes, sir.
Okay.
Yes, sir. Please.
Now, tell me one thing. We are following the European guidelines, American guidelines, the sepsis campaign guidelines. First, tell me this thing, which you are following. Which one you are following?
So we're following the surviving sepsis campaign guidelines only, sir.
Okay, I will ask you another thing then related to that. Do you think that we, sitting in the tropical country, with the resource challenge scenarios, with limited resources, not non-uniformly distributed resources, manpower, equipment, or the medications even, a different subset of medications, if you go, forget about the generic part that I'm not going to discuss, with a high brand, with a low brand, with a high price, low price, antibiotics and all those other stuff in the medications. Do you think we really require a different set of guidelines? Septic patients in our country, where the flora and fauna of everything is different, the bacterial isolates, their strains, their refractoriness to the treatment, their resistance, their other things are altogether different to the European countries, where the guidelines are formulated according to their data, rather than going to the aggressive data compiled from the Indian or Asian societies. So do you think that by following those guidelines or by making our own guidelines for the surviving sepsis campaign, whatever you can call, can we achieve that?
Yes.
Yes, sir. As you told, the floor.
The gold medal question, you have to tell me properly, how will you achieve that?
Yes, sir. Sir, the first intervention is early ICU admission. But
no, understand the question first. Why do we need different guidelines for our own patients in India, a tropical country where the climatic conditions, environmental conditions, resources are different from the Western, who have dominated by making those guidelines, and we are supposed, and they are imposed upon a Indian population, or you can say the South Asian population. Do we really require a different set of guidelines to treat these patients more effectively, more diligently, rather than, see, if you go by those standards, their treatment are very costly. You cannot apply those treatment patterns to every patient in our country. And in not doing so, according to their guidelines, we may lose many patients. We may have a higher morbidity, higher mortality, because we will not be able to implement those guidelines in our setups. That's what I want to know. How will you develop our Indian guideline? This question is a policy making for a third year student who will be going for the examination. If you can answer this thing, you will get a gold medal. I'm telling you. I'm not supposed that you will. Actually, I'm not expecting this to be answered by you. But if you can answer, that will be a very good answer.
So many of these guidelines that are recommended to us are performed, like you said, are performed in resource-rich areas, and in resource-poor areas and resource-limited areas, the research is still in place. So what we can do is we might not be able to follow all the guidelines, all the 90 guidelines that they have listed out, but we can use this as a framework to form our own guidelines. And this would again require adequate research. For example, the inclusion of capillary refill time, which is an update in 2021 guidelines, was again indicated for areas where resources are limited, for where we can't use cardiac output or stroke volume output. We can use this, and the Andromeda shock trial had compared it with lactate resuscitation guided to lactate targets and capillary refill time targets. So we can identify certain investigations or certain strategies that can be followed in a low income areas, and again research should only get us there.
Sir, and one more thing is, as you told, the flora and fauna is different from what we have and what the Westerners do. About the bacteria, antimicrobials, in the Western countries, gram positive is more predominant, and in ours it's gram negative. And we have a few viral infections like dengue, malaria, which are endemic to the tropics and the subtropics. So, and these diseases initially present as sepsis. So, including these into the treatment guidelines, and fluid resuscitation as soon as the patient comes to the emergency department, and improving the we not all institutes have ICU setups. So having a better monitoring and diagnosis infrastructure in terms of diagnosis and treatment at whatever is available would be the necessity, sir.
Nice. Okay, I think you have tried to answer it. I can supplement it further. It's not about just going into the RCTs every time to formulate guidelines. RCTs is just an explanation, it's an excuse for us to go for those guidelines. Ideally speaking, when you have a data, or published data, or observation, or even observational data you have got, it's well and good. But to formulate guidelines in a sepsis, you have to talk to all the stakeholders, especially the people in the diagnostic arena, or maybe the pathologist, the microbiologist, because whatever the knowledge and strength of diagnosis they have got, they will be more helpful for making a complete set of guidelines for our Asian society, or you can particularly say Indian society. So here comes a role of policymakers to involve actively, or you can do it yourself at your own level by involving the different stakeholders in all the diagnostic arena as well as in the therapeutic arena. You have to involve these people to go ahead with the formulation of particular standards of diagnosis. You may not require the whole battery of tests, okay, to label it as a septic shock or a severe sepsis, whatever. But you require a minimal level of, these are the minimal level of biomarkers or minimal level of diagnostic criteria, which can establish the initiation of aggressive treatment as well as the further treatment of these patients. Similarly, the way we evolved during the COVID times, right? See, in the 1.5 years, we evolved from a diagnostic pattern to an entirely different diagnostic pattern by the end of 1.5 years. Similarly, we can go for these things also, but here we require the cooperation and coordination with the other specialties, especially the diagnostic specialties. You can do it, but you are trying to answer in a very fine manner. I am proud of it, and you are doing very well today. I think few more questions and you will be more happier than answering them. This is a different question, but you were able to answer 50 to 60% of it. I think Dr. Madhuri has raised hand. Let her also ask her query.
Yeah, I have to answer the question, no, which I had asked. So Neha and Bhuneshwari, no need to worry. Rotrigogin alpha, as you said, you have not heard of it as right, because it was a drug which was a recombinant form of activated human protein C, and it was known by the trade name of Zigris, and it was used in the treatment of septic shock, but it was withdrawn from the market some 2 to 3 years back. Okay, so it is no longer there in the guidelines. And secondly, what is the role of the microcirculation in this management of shock? You know, what I feel is that if research on the microcirculation is very important, if you have to come out on new modalities of treatment. And in fact, when I was going through literature, I found that there is a separate journal on microcirculation. So many things happen in the microcirculation, and research on microcirculation will bring out new modalities of new therapies and new modalities of management, I feel, in the management of sepsis.
Neha,
No,
if you don't, if you are not able to answer this question, I will answer it for you. Don't worry.
No, there is nothing to answer. Like, you know, I told you that there is an important role of the microcirculation there, right? In the management
Yes, ma'am.
of sepsis. And yeah, so want to add anything to this microcirculation?
Yes, ma'am. So in shock, the primary dysfunction is at the level of endothelium. So endothelium forms our functional unit, and it is
Not only in
responsible
shock,
for
not only in shock, the microcirculation is said to be involved in various other disease conditions. So much of research is taking place on the microcirculation. That's what I was saying. There's a separate journal of microcirculation. So you can imagine how much of research has to take place in that area. Okay. Okay.
Dr. Madhuri, the only problem with the microcirculation monitoring and diagnosis is the monitors are very, very costly. Very, very costly monitors. They are going into lakhs. And the modules, they are available in certain setups in India. But that research will be confined to those patients which are already under a very good particular team where the resources are in plenty.
Yes.
We will be able to do research in those things. One question is, I think, coming here about the sepsis in the laparotomy patient in emergency setup. It's happening every day. Almost in every setup, we get from a variation. You get a resources variation. You get a patient of laparotomy. In those setups, it's very difficult to go with the treatment, the diagnosis at the right time, and so many other factors. The limitations are there. But the microcirculation monitors are there. Definitely, your point is very valid. We have to go for the higher research to get a result from the microcirculation parameters. But at the moment, I think the costly affair, the limits are, and we always lag behind the Western countries because we don't get the good equipment. And they will be doing all the small neurotransmitter research, and they will publish in all the anesthesia analgesia. And we are just limiting to comparison to our drugs between two drugs and doing all those comparisons small, and the theses are being done like that. What we can do here, there are certain things, the biopsychosocial aspects, the biophysiological aspects. There are many aspects on which research can be done, including the microcirculation. I think we can do one center having a microcirculation, their findings, one without a microcirculation monitors, their findings, and implementation of our own protocols on both the setups, and considering whether the microcirculation monitors are really superior or something like that. The way the desflurane found its way in the anesthesia, and now it's a completely obsolete drug. So many things will be obsolete, many things will be accepted. So I think these things are the things for future. For 5-10 years down the line, we will be able to get more things. And many people who are listening to this class, they should volunteer themselves to be the part of such group of guidelines and protocols. If they are willing, they can write on the mail our isnhqvaper@gmail.com or isnhvaper@yahoo.com. You can give your opinions. We can involve you in the future also for the formulation of such protocols and guidelines from the ISN national side. That I can assure.
Yes, sir. As you said about microcirculation, many times we just try to maintain our endpoints of resuscitation, but still the patients don't come out. This is because nothing much has been done about microcirculation. There's so many things which happen at that level. So that is a point where we need to really stress on.
Yeah, definitely. Those are the limitations. Actually, we have to find out the limitation, the biases, the confounding factors here which can prevent mortality and morbidity in such patients. And those really need research. And I think the subset of patients we are having in India, they are much more. The number of the patients is much higher than the patient in the West. But the guidelines of the West, which are cannot be implemented in a uniform manner or in a holistic manner to all the patients in our country. That's why I think this idea is important. So all of you are welcome who can think that they can make a difference to this. You can come out with the guidelines, with the research, able to do some little hard work. So we can involve a committee here. We can go for the guidelines for the sepsis for our own Indian, or we can go with the collaboration with the South Asian countries also.
The only thing, as you said.
Yeah, sir. Please, sorry. Yeah.
The only thing, as you said, the Western countries have so much of support. So for such things like that, now I need to have good support not only from the institute, but from the society as well.
Yeah, sir. Definitely, sir. I think it's a multi-centric phenomena to form such guidelines, because I've been a part of the guidelines for the Endocrine Society of India. The people are from all part of the country. It's not just because the different zones, the different states have got a different subset of patients. There are different, because the cultural and religious variation, there is a presentation is different, the symptomatology is different, and the strains are also different. So that's why I'm saying, if we go ahead with this thing, we can come out with a very strong set of guidelines and protocols. The idea is clear. The only thing is the initiation and well as some initiative taking people in this format. That's what I want to involve people here. And see, ISA National will definitely, it's an endeavor by the ISA National to go into these type of things. We are ready to do it, but we require the people who can really take a hard work along with us. We definitely welcome everyone for that. And I really appreciate, see, Neha and Oneshwari, you people, the way you have answered, it shows a lot of mettle of teaching to making you such a prodigy in the PG curriculum that you are able to answer so meticulously without blunder and a very systematic manner. And you also shows your wittiness and wisdom in answering certain queries which were going little bit on the board. So I can congratulate Dr. Rajesh Mane sir and Dr. Patil sir. They have done a wonderful job. I don't think in preparing you, rather than they're all PGs. It is for all PGs.
The credit goes to the students here.
That goes. But yeah, teachers said, without teachers, no student can progress to that level. So that is for sure. Really good effort. Josna, just ask if anybody wants to know any more suggestion or question, please.
Yes, the house is now open. Please ask any questions. Although a lot has been already discussed in the chat box and probably most of it has been covered.
See, so many compliments. I'm going through chat box. So many compliments today for Neha and Aneshwari.
The pages, both of them have done really well. It's commendable the way you're prepared.
I think they were just giving answers like an assistant professors, not like a PG student today.
Yeah. Okay.
I think so. They don't.
Anyway, like to thank the ISN National for giving the opportunity for the department to myself and Manjunath, and also to Neha and Vaneshwari. Yeah, Neha, you want to say something?
Sir, I wanted to thank ISN National for giving us this opportunity to present at a national level. And I would also like to thank Mani sir and Manjunath Patil sir for guiding us through this. Like sir has said, without their guidance, we could not have come to this level. Really grateful for this opportunity.
Remain like that always till you become teacher yourself and HOD of an institution. Remain like that. Okay. For the time being, I just want to share certain things. Felicitations have to be there. Is my screen visible now?
Yes, sir.
Yes, sir.
So this is a certificate of appreciation, and we are really honored to have teachers like Dr. Rajesh Mane on the board here. Sir, is your certificate for today's class.
Yeah, thank you, sir. Thank you. Thank you for the opportunity.
Then Dr. Manjunath Patil sir, your certificate.
Thank you, sir. Thank you, sir. Thank you very much.
Really very honored to have you here also. Then
Thank you.
Oneshwari and Neha, you have done a wonderful job. I'm proud of it. You should be doing very well in your examinations whenever you're going to face them. So best of luck for your future endeavors also.
Thank you so much, sir.
And Mithila, this was your debut on the
Yes, sir.
screen. So basic idea is the people who are coming on the screen at your level. So you are going to be anchoring, you are going to be the part of the academics, national academics from every part of the country. People who have got the talent, they should come forward. Just like India got talent, so we have got talent here. So you will be coming for the national academics. So this is your certificate.
Thank you, sir.
And Dr. Josna, as usual, she is a senior coordinator and always helping the newcomers. So Josna, thank you for being there. This is from my side, from ISN National side. ISN National means myself, Dr. Madhuri, and all the team, even Dr. Josna. So we are all the part of a team. So that's I think it's one of the best discussions.
Yes,
And discussion at the level of PG students taking part in a discussion. You will go to a different conferences. You will see all the stalwarts sitting there, all the big names are sitting there. They will be discussing on a particular prepared questionnaire in the panel discussion and allow the audience only for 1 or 2 questions. But here the PG students are answering to all the battery of the questions and to their sirs also question and to all the people who are asking them any type of question. So this is called a real interactive panel discussion or interactive class. The idea is coming at very good and the PG students are getting confident day by day. I'm really thankful to the teachers who have prepared the students very well today. I think it was a very good class. I was thinking that we can have one more class, but I think they have given us enough answers today. So we will change the topic next time. So thank you, Dr. Rajesh sir, Dr. Patil sir, and all my students, Dr. Neha and Dr. Aneshwari, and Dr. Madhuri, Dr. Josna, Dr. Mithila. Thankful to you. And I think we should close the session today. It's almost 8:17 now.
yes.
Okay. Thank you, sir.
Yes.
Thank you. Thank you,
Thank you,
Madhuri
sir.
ma'am.
Thank you for the opportunity.
We always end by saying, long live ISA.
Yes, sir.
Long live.